Hello and welcome to the Pain Options Education channel. This here is Tim.
And that's Darren.
This is our ongoing saga, the Pelvic series, and we're up to the odds and sods section, and this is about the symphysis pubis today. But we have done some other content around assessment and management of sacroiliac joint and pelvic girdle pain in general, but thought we'd just add some information around the symphysis pubis because it can be forgotten when you're talking about the sacroiliac joints so much.
So as far as the pelvic girdle pain, that's part of the pelvic girdle, isn't it, the symphysis pubis?
Yeah, absolutely, and lots of the research into pelvic girdle pain during pregnancy talks about symphysis versus sacroiliac joints versus having both as well and seeming increased severity with the more sites of pain.
So is pain in the symphysis region, I guess, more common in the pregnant population than otherwise?
I really have no idea. Okay. No. But it does kind of allude to the differential diagnosis point, and we had the epidemic of osteitis pubis in Australia with younger athletes, potentially older ones as well. And yeah, you know, is there symptoms coming from the symphysis itself, hip adductor tendon through there, maybe the hip joint referring into that area, conjoint tendon, other differential diagnoses?
Yeah, around iliopsoas and inguinal hernia were the other ones. So they often talked about athletic groin pain broadly covering those regions.
So is that cluster of disorders more common than true symphysis pain in pregnancy? I don't really know. Don't have a feel for that.
Well, certainly no. With those athletes, there was a period of time where injections into the symphysis were being done, sometimes surgery, including removal of the disc as part of a four-pronged approach, certainly with the higher level athletes.
Yeah.
But we know that certainly can be a source of symptoms, but there's that differential diagnosis that is important around that area.
Yeah. So, well, around that, in terms of the subjective assessment then, it seems obvious to say it, but symphysis pain is usually over the symphysis, right?
Yep.
Yeah. It's not even really to the left a little bit or to the right a little bit. It's pretty central, or do you think it can be more to one side?
Well, if it's truly the symphysis pubis, I think it's central. Yeah. Anything that's more lateral than that, then you start thinking other structures such as adductor tendons, for example.
We spoke about the injection studies in the sacroiliac joint, and they're using that as a way to determine referral of symptoms. And the same studies haven't really been done in the symphysis pubis to see if it refers. I know one lady that did a study on injecting the symphysis pubis during pregnancy. Asked her specifically, did she think the symphysis refers pain? Her answer was no, and that would be my feeling on that as well. I think secondary pains seem to be muscular. Yeah. Okay, anything else particular you would ask about or think about subjectively during assessment of the symphysis pubis that might differ from what we've already discussed?
Well, it doesn't differ, but the issues again around what's driving it. If it's mechanical, again, transfer of load through the symphysis pubis, which can be through weight bearing, or it can be through muscular contraction. If you think about the attachments, obviously the abdominals, and then also some of the hip and groin muscles that will obviously the adductors attach directly to the pubic ramus, for example. So they would be structures or activities involving contraction of those structures, I guess, could put stress or load through there.
Yeah, I guess I can hear our one sports physiotherapy viewer out there screaming load management during training as a potential other thing you might want to look at.
Yeah, but that comes to the story. Is it mechanical pain? Is there clear loading, aggravating or easing? Or is it again more non-mechanical where there's something inflammatory going on or more of a pain sensitivity presentation? So again, listening to the story, I think the key, I guess, components of the subjective interview don't differ other than obviously questions around location of symptoms.
Yeah.
Yeah, and you might ask ruling out questions, you know, your hernia type stuff in terms of coughing or sneezing, for example.
Yeah.
So there'd be that type of approach of your questions specific to other structures in the region.
Yeah. Yeah, I can't think of anything else subjectively there myself. So, moving on to the physical examination, we went through a reasonably well validated system of provoking pain from the sacroiliac joints. There isn't such a system for the symphysis pubis. You hear about some tests that are meant to stress that more. Fabers, I think, is one that comes up. But in general, I think any test that puts load through the symphysis can potentially provoke pain from there.
Yeah. So they may be movement tests or provocation tests that stress or move through that region.
Yeah.
Again, not that there's a huge amount of movement, but those end range positions will put stress across there. Plus, there's the physical loading, like your weight bearing on your leg, your transferring load, hopping, jumping sort of things, and then muscular contraction. So if you contract the adductors or the hip flexors or the abdominals, arguably that might put some stress through that region, but that doesn't mean the symphysis alone, because that's stressing other structures at the same time.
It is. And trying to modify movement behaviours in the way that we previously discussed might be part of that, to see if that changes the load through there.
And the other key one's obviously palpation.
Yeah, that came to my mind as well. So, look, that is a key thing to do, and certainly that needs to be done with consent and tact almost around that, as all of these pelvic tests do. Any complaints against physiotherapists are usually around the area of the pelvis, so you need to be extra careful on consent and be clear that the patient understands what you're doing.
So how would you go about that in explaining to the patient what you're going to do to gain consent?
Yeah, I think in that case I do explicitly be very clear on what I'm about to do, and get the pelvis and show them and say, well, look, this is your area of pain. We just want to confirm where the sensitivity is around there. I might palpate through their thumbs in some instances. I think that's a reasonable thing to do.
That's one you can guide the patient and ask them to
Self-palpate,
feel through that area and point, and then if they're comfortable, then you can push on their fingers or thumbs as well.
Yeah.
So you just need to be clear that you are on the right site.
Yeah.
So getting the location right is important, because obviously things like adductor tubercles mean something quite different to symphysis pubis, for example, or the inguinal region around hernias, or the attachments of the abdominals on the superior part of the pubic ramus there.
Yeah, good. Examination-wise, I think that's probably it. Management-wise, anything particular about these disorders? Again, maybe that's different to what we discussed for the pelvis in general.
I think, again, the principles apply, but you would target that to the patient being clear on what are the aggravating factors if it's mechanical, and can you either modify that so it doesn't aggravate, or is it a load management issue like you mentioned before, where you need to reduce stress on the area to allow it time to settle down. Because most of these aren't a trauma injury where something's badly damaged. It's either sensitive or inflamed, and management around making that less sensitive is really the focus, I think.
And my mind does go back to working in women's health practice, or the large component of women's health, and those poor women where they had this during pregnancy and it was just highly resistant to treatment, highly resistant. I mean, you could make them feel better for 5 seconds while they're lying down there, but then they'd get up and it would be no different. So I think you do need to have strategies to manage that, and you mentioned hydrotherapy before as a potential way to take a load off the system and keep them moving. And also it's probably important to remember that for most women with pelvic girdle pain during pregnancy, for the vast majority, that goes away shortly after birth. So being positive around the outcome of this is important. Management-wise, I can't think of anything else.
Well, the other comment is don't overcomplicate it, or don't try and mystify it.
Yes.
Make sure the story makes sense, and engage the person in a collaborative plan around designing how you can get them activating again, whether that's through progressive exercise or actually calming it down first and then resuming activity.
Okay, good. So we're open for questions at education@painoptions.com.au. Do you have any questions, Tim, to finish off with?
No, I think I'm good for now. Thanks, Darren.
You've learned everything you need to know about the symphysis pubis just now.
I don't know about that, but it was a helpful chat and I enjoyed it.
Good. See you. Oh, no. Well,
We will see you.
We will see you, or maybe you'll see us when you look at our previous episodes if you haven't seen them all. And we have one more in this series, the odds and sods of the coccyx. So looking forward to that. Better get out the gloves, Tim.
Excellent.